Hello viewers and the 5 postgraduate ENT students who requested me to make a video on rhinoplasty. Today I will talk about rhinoplasty from the point of view of a postgraduate ENT student who has been asked to write a 10-mark answer on rhinoplasty in 15 minutes. Rhinoplasty is a particularly difficult topic to negotiate for a 10-mark answer in 15 minutes because rhinoplasty is a topic on which several books have been written. While conducting a brief research before making this video, I came across rhinoplasty as a question several times. It is one of the most frequently asked questions in theory papers for postgraduate ENT students. It has been asked in various forms. Sometimes it has been asked as rhinoplasty for correction of saddle nose deformity, sometimes just a description of spreader graft, what is internal nasal valve, what are spreader grafts, discuss augmentation rhinoplasty with respect to spreader grafting, discuss nasal tip correction in modern rhinoplasty, discuss augmentation rhinoplasty with respect to spreader grafting, describe different incisions and approaches of rhinoplasty, and so on and so on and so on. So in today's video, I will first talk about the different approaches of rhinoplasty. This will include discussion about the different techniques of nasal tip deformity correction and reduction rhinoplasty. Then we will talk about saddle nose deformity. We will then move on to augmentation rhinoplasty. Then we will talk about spreader grafts, and finally we will conclude this video by talking briefly about internal nasal valve. So I hope at least the 5 postgraduate ENT students who requested me to make a video on rhinoplasty will watch this video till the end. Let's get into it. Rhinoplasty can be done to improve the appearance or function or both of a person's nose. So it is not just a cosmetic surgery, it can also have indications to improve the function of a person's nose. Indian literature suggests rhinoplasty was first done by Sushruta, whereas in Western literature, John Orland Rowe performed the first intranasal rhinoplasty in 1887. Sometimes septum is also corrected while performing rhinoplasty, and then the procedure is called septorhinoplasty. So septoplasty plus rhinoplasty equals septorhinoplasty. There are 2 approaches of rhinoplasty: external or open approach and internal or endonasal approach. In the external approach of rhinoplasty, a skin incision is present externally, whereas in the internal approach of rhinoplasty, no skin incision is present externally. The configuration of nose is different for different patients. Each rhinoplasty patient requires individual planning for surgical reconstruction. The different aspects of rhinoplasty planning include amount of tissue to be excised, amount of tissue to be augmented, area of anatomical correction, thickness of skin associated, and nasal pathology or trauma. The principle of septorhinoplasty includes septoplasty, tip correction. Tip correction includes remodeling, projection, rotation, removal of hump, that is reduction rhinoplasty, narrowing of nose with osteotomies, and final correction of deformities. Now we will talk about external approach rhinoplasty. The incision in external approach rhinoplasty is transcolumellar inverted V incision to minimize resultant scar to make it invisible postoperatively after healing. Incision is then extended posteriorly along the margin of lower lateral cartilage. Skin flap is elevated using sharp scissors as opposed to blunt scissors, which will not do anything, to expose nasal tip and lower lateral cartilage. Septal flaps are elevated on both sides. Septal cartilage is separated from lower and upper lateral cartilages. Hump is then directly visualized and is corrected before doing any other procedure. So the first procedure you do is hump correction, not even septoplasty. Incision and excision of a portion of upper lateral cartilage may be necessary for correction of dorsal deformity. Median oblique osteotomy is done. Lateral osteotomy is done till the level of frontomaxillary suture line at the root of the nose. Now an important point here is, here I am talking about rhinoplasty, not septorhinoplasty. And I am an MBBS, MS, MRCS, so you can trust my answers. So in this answer, we are not talking about septorhinoplasty, we are talking only about rhinoplasty. Moving on. So median oblique osteotomy was done. Then lateral osteotomy was done till the level of frontomaxillary suture line at the root of the nose. Now both lateral osteotomies are joined together in the midline. Cartilage and bony framework is mobilized and brought to the midline to correct the deformity. Depressed nasal tip can give rise to a pseudo hump, which can be corrected by correcting the tip deformity. depressed nasal tip can be due to three causes: excessive resection of inferior strip of cartilage during previous septal surgery, gross subluxation of nasal septal cartilage, and fractured nasal septal cartilage. Now, tip deformities can be bulbous tip, narrow or pinched tip, bifid tip, under projection of tip, over projection of tip, and rotated tip. Now let's talk about how to correct each of these tip deformities. Bulbous tip correction involves division of lateral crurae of lower lateral cartilages in two strips, that is medial and lateral. Medial strip is rotated and sutured in midline. Interdomal suturing may be required. For pinched nose, correction is done by making multiple incisions at strategic sites to open up the nasal tip. Bifid nose corrected by suturing two medial crura of lower lateral cartilages at the dome. Under projection of nasal tip is corrected by using a tip graft like a cartilage. Over projection of nasal tip is corrected by reduction of alar dome. Rotated tip is corrected by using tip delivery technique or open approach. Tip delivery technique will be explained later on in this video. Now, hump, if present, is due to excess of bone or cartilaginous skeleton, and it does not produce any functional disturbance. It is just a cosmetic problem. Small humps can be corrected using rasps. Reduction rhinoplasty may be performed to remove bigger humps. Reduction rhinoplasty involves resection of excess bone or cartilage using osteotome or knife. So excess bone, osteotome, excess cartilage, knife. Median and lateral osteotomy is done to narrow the bridge. At the end of the surgery, that is at the end of external approach rhinoplasty, splint is applied to help the nose maintain its new shape. Nasal packs may be placed in nasal cavities to stabilize the septum. So with this, we have concluded external rhinoplasty. If you have any questions, please feel free to comment below. Now we talk about internal approach rhinoplasty or endonasal rhinoplasty. For this, the incision is complete hemitransfixation incision. Mucoperichondrial flap is elevated on the concave side of nasal septum. When tip refinement, volume reduction, and tip projection is necessary, transcartilaginous incision is preferred, known as tip non-delivery approach. Now we will talk about tip delivery. Tip delivery technique for nasal tip deformity correction involves making intercartilaginous incision, carrying out dissection between upper lateral cartilage and lateral process of lower lateral cartilage to separate nasal cartilage from overlying skin. Overlying soft tissue and periosteum over the bony framework is elevated using periosteal elevator after incising periosteum over the nasal bone. Hemitransfixation incision is then joined with intercartilaginous incision. Septum is separated from upper lateral cartilage by sharp dissection. In the presence of external deformity involving cartilaginous framework of nose, both lateral cartilages are separated from the septum. Septal deformity, if present, is corrected before correcting external deformity. Cartilaginous deformity corrected before correcting bony deformity. Upper lateral cartilage corrected by making strategic wedge resection or incision. Cartilaginous hump is corrected by reducing cartilaginous portion by knife caudally from nasal bone to caudal end of septum. Height of upper lateral cartilage reduced by using straight iris scissors. Bony hump is corrected by using 4 mm osteotome. Small bony humps can be reduced by using a rasp after elevation of periosteum from nasal bone. Bony framework correction and narrowing is done by osteotomies after the hump excision to oppose the flat dorsum thus created. Median osteotomy is short and directed along the line of intended fracture. Curved low lateral osteotomy is done to prevent trauma to surrounding structures. Lateral osteotomies carried out through pyriform aperture. Small incision is made at pyriform aperture to create a small periosteal tunnel. A guarded osteotomy is preferred for lateral osteotomy. Lateral osteotomy should be as near to medial canthus as possible, but care should be taken to avoid injury to lacrimal sac. The lateral osteotomy should be kept lateral to the lacrimal sac. Lateral osteotomy lateral to lacrimal sac. Low lateral osteotomies are facilitated by medial oblique osteotomies angled laterally, approximately 15 to 20 degrees from vertical midline. Low lateral osteotomies in conjunction with medial oblique osteotomies produces less trauma. prevents asymmetries and requires less manual pressure in comparison to a low curved lateral osteotomy alone. Multiple or triple osteotomies are required for post-traumatic scoliotic or crooked nose to facilitate proper bony realignment. Realigned bony fragments stay attached together, usually by fibrosis. After completing osteotomies, nasal framework is realigned, septal splinting is done, followed by external nasal splint to support and keep nasal framework in place as well as to protect external nose from trauma. Now we have concluded internal approach rhinoplasty or endonasal rhinoplasty as well. Now we will talk about saddle nose deformity. Saddle nose deformity can be caused by trauma or it can be caused by infections. Road traffic accident, sports injury, accidental injury as well as iatrogenic injury like submucous resection of nasal septum are examples of traumatic causes of saddle nose deformity. Infections that can result in saddle nose deformity are syphilis, tuberculosis and leprosy. Saddle nose deformity is a dorsal deformity of the nose, usually due to reduction in dorsal height of septal cartilage. Saddle nose deformity is corrected by performing augmentation rhinoplasty, where the defect is augmented by either using cartilage, bone, or a synthetic material like silastic. Columellar strut may be required due to loss of caudal end of the septal cartilage. Now we will talk about augmentation rhinoplasty. It is a surgical technique involving use of graft material to correct deformities like saddle nose deformity, retracted columella, etc. The basic principles to be kept in mind while selecting graft material are: nose is a hazardous recipient area, there is no single best graft material, synthetic materials tend to extrude, hence they require a good thick layer of soft tissue separating them from internal or external surfaces. Natural materials get absorbed to some degree, particularly cartilage gets absorbed in contact with blood. So synthetic materials have a tendency to extrude and natural materials have a tendency to get absorbed. The commonly used graft materials for augmentation are bone. When it comes to bone, which bones are used? Iliac crest or tibia. Tibia gives natural contour and is an excellent graft material for correcting saddle deformity of the dorsum. Cartilages can be used like septal cartilage, conchal cartilage from the ear, rib cartilage. Now septal cartilage may be useful but not available because it may have undergone necrosis which caused the septal deformity in the first place. So deformity in the septum may be the reason why saddle nose deformity exists. So maybe adequate septal cartilage may not be available. Synthetic materials like silastic and Teflon can also be used as graft materials in augmentation rhinoplasty. Now, external rhinoplasty approach is preferred to internal rhinoplasty to prepare the graft bed in augmentation rhinoplasty. Overlying skin and columella lifted up adjacent to caudal end of septal cartilage after a routine external rhinoplasty approach using a dorsal retractor. Now, I will not talk about external approach rhinoplasty again, I have already discussed it. So we will move on. Alternatively, in the internal rhinoplasty approach, intercartilaginous incision is made and the overlying skin and soft tissue is retracted from the dorsum using a dorsal retractor. Soft tissue over nasal bones dissected and separated with the help of a sharp elevator. Bony surface is made raw. For reshaping of bony surface, medial and lateral osteotomies may be needed. Once nasal bed is prepared, a suitable natural graft material is harvested or a synthetic graft material may be used in case of non-availability of natural graft materials. Graft is prepared according to the length and height required. Graft should be shaped in a way to ensure it comes down to the septal angle and no further. Graft is gently inserted into the target area. Incision sites are closed by catgut 30 for transcartilaginous or intercartilaginous incision, and 60 proline is used for closing external rhinoplasty incision. Spreader grafts. So we have completed augmentation rhinoplasty. We will now talk about spreader grafts. Rhinoplasty can compromise nasal valve, giving rise to complaints of nasal obstruction following rhinoplasty. So in this event, we can use something called spreader grafts. Spreader grafts can be placed to open up the nasal valve area to improve both function and provide cosmetic benefit. Spreader grafts can be placed via both the external and the internal approach. External approach allows easier and more precise placement and suture fixation of such spreader grafts, minimizing risk of displacement. Cartilaginous strips are placed longitudinally between upper lateral cartilage and the septum. Mucosa between cartilage is often divided, but based on Sheen's original work, this should be avoided and spreader grafts placed extramucosally instead. Spreader grafts can be well placed endonasally as well, into tight submucopericordial pockets and held with tissue glue or with percutaneous transseptal sutures if required. Unilateral placement of spreader grafts may also correct asymmetries of dorsum. Using the open or external approach, spreader grafts can play an extended role, including lengthening an overly rotated nose with articulation onto septal extension grafts, maintenance or reconstruction of the dorsal nasal roof, straightening of a high dorsally deviated septum, recreation of dorsal aesthetic lines. Now the final topic for today's video is internal nasal valve. Internal nasal valve is the narrowest part of each nasal airway. Boundaries of the internal nasal valve include inferior turbinate head, that is head of the inferior turbinate, upper lateral cartilage and nasal septum. Cottrell's maneuver tends to improve all nasal airways and therefore is not advocated as a usefully discriminant test. So Cottrell's test is not an exclusive test for internal nasal valve. Cross-sectional area of internal nasal valve area should be assessed at rest, at normal inspiration and at forced inspiration. Any restriction in the internal nasal valve area may be due to septal deformity, may be due to engorged turbinate, may be due to internal nasal valve collapse. Now this collapse can be static, it can be dynamic. Static collapse is usually due to deformity in upper lateral cartilage, whereas dynamic collapse is due to weakness in upper lateral cartilage. Now in static internal valve collapse, there is an acute valve angle of less than 15 degrees at the junction of septal cartilage and upper lateral cartilage. Sometimes the angle can be more than 15 degrees, but still can have nasal valve collapse because of poor septal support, resulting in a shallow valve height. Finally, the clinical evaluation of nasal patency can be confirmed with helpful adjuncts like tests like peak nasal inspiratory flow, nasal vapor condensation test and nasal valve splinting tests. So with this, I end this video on rhinoplasty. I hope this benefited the 5 postgraduate ENT students who requested me to make this video. The reference for this answer is 8th edition Scott Brown and another book which I shall not name. If you find any factual inaccuracies or if you have any doubts, please feel free to ask me in the comment section below. Take care, bye bye, and please don't forget to be awesome.